I beg to move that this House do now adjourn.
The question is that this House do now adjourn. Nadine Dorries.
Thank you, Madam Deputy Speaker. And I'm absolutely delighted and honoured tonight to have been selected to call this to give this adjournment debate on Group B Streptococcus, which is known as Group B Strep, or simply GBS. And for the rest of this debate, I will refer to it as simply GBS. GBS is recognised as being the most common cause of serious infection in newborn babies, and in the UK is the most common cause of meningitis in babies in their first weeks of life. With prompt and aggressive treatment, most of these sick babies will recover from GBS infection, but even with the best medical care, around 10% of these sick babies will die, and some of the survivors will suffer lifelong problems, including 50% of those recovering from GBS meningitis. This subject was last raised in the House 10 years ago by the Right Honourable Member for Witney, now the Prime Minister. Given his current position as the Prime Minister, it would be encouraging if we could see more progress move forward, and we have seen some progress, but it would certainly be encouraging to see more. And in fact, I will quote the Prime Minister's words at the end of my speech. The rate of reported cases of culture confirmed Group B Strep infection in newborn babies increased by almost 50% between 1991 and 2010. The true rate of infection, which includes cases not confirmed by specifically identifying the bacterium but is strongly suspected clinically, is likely to be several times higher. It is therefore not only a very serious issue, but one that is becoming more serious with time, not less. We have known for a very long time that the key risk factor for a newborn baby developing GBS is the mother carrying GBS at delivery. UK guidelines state that when GBS has been detected during the current pregnancy from a swab or culture from a pregnant woman, she should be offered intravenous antibiotics in labour to minimise the risk of GBS developing in her newborn baby. The UK's risk-based strategy used to reduce GBS infection in newborn babies was introduced by the Royal College of Obstetricians and Gynaecologists in 2003. We have seen no evidence that it has appreciably reduced the incidence of these devastating infections. In 2003, there were 229 reported cases of GBS infection in babies aged 0 to 6 days. In 2011, there were 281 cases. On this evidence alone, I would suggest to the Minister that the risk-based strategy has demonstrably failed, and we now need to consider new alternatives. One UK study found that 21% of women carried GBS and 22% of women had risk factors for GBS infection developing in their newborn baby, and so would be offered intravenous antibiotics in labour. However, only 29% of women with risk factors actually carried GBS. Using risk factors alone means a high proportion of women not carrying GBS will be offered intrapartum antibiotics, whilst many actually carrying GBS will not.
Order. I'm sorry to interrupt the Honourable Lady. We have to do a procedural motion.
Madam Deputy Speaker, I beg again to move that the House be now adjourned.
The question is that this House do now adjourn. Nadine Dorries, you could start.
You want to, but...
You don't need to start right back again, do you?
Just carry on. We followed the flow.
The research has stated the most striking finding that has implications for clinical practice and policy is the low sensitivity of risk factor-based screening compared to the PCR or culture test in predicting maternal and neonatal GBS colonisation.
Would my honourable friend give way on that point?
Certainly.
First of all, may I warmly commend her for bringing this issue to the House, and I have a constituent who lost a child to this issue, so it's something I take very seriously. Is she pleased, like me, to see Public Health England is now adopting a gold standard in rich culture testing in its 8 regional laboratories, and does she welcome that as a small advance in this important area?
I welcome the honourable member's intervention, and actually I go on to talk about the gold standard culture medium in the speech. Below that which we considered to be minimally acceptable sensitivity for our study, which calls into question the validity of the current UK policy. Moreover, consistent with previous evidence of practice variation, the risk factor-based screening policy was poorly adhered to, with 1/3 of women with indications for IAP not treated. Despite these authors and numerous others recommending routine screening as being cost-effective in the UK National Screening Committee continues to recommend the risk-based approach. Most countries which have national strategies against GBS infection offer routine antenatal testing for group Strep B. These countries have seen an incidence of early onset disease fall dramatically. For example, in the US and Spain by over 80%. This compares very favourably indeed as the result of the risk-based approach used here in the UK, which I've just mentioned is actually seeing the increased number in infections. And so if the risk-based strategy which we are adopting here is actually not working, we know it's not working because the number of infections are beginning to increase, and yet countries like Spain are seeing an 80% reduction. Should we not be considering the cost effectiveness of moving to a system which we know will reduce the number of babies that we see very poorly in our ICU units with group B Strep B induced meningitis and other complications? Studies showing that testing for group Strep B in late pregnancy, plus offering women to found to carry GBS and those other recognised risk factors, is more cost effective than the current risk-based strategy. A risk-based strategy is poor at predicting women who will be carrying GBS in labour, and therefore which women who have antibiotics in labour would potentially prevent these devastating infections in their newborn babies. Furthermore, recently published research shows that women want to be informed about group B strep and offered testing for it during pregnancy, and yet this just isn't happening. The tests themselves are not that expensive, less than £12. And the antibiotics recommended in labour when a woman is found to carry GBS in pregnancy is a cheap, cost-effective antibiotic. It's penicillin, a drug which has been shown to be exceptionally safe, as well as being a narrow-spectrum drug, which is unlikely to cause greater resistance later. Currently, most NHS pathology services use culture media which is general purpose and only identifies GBS in about 60% of carriers. At the request of the Chief Medical Officer, Dame Sally Davies, from the 1st of January 2014, the enriched culture medium, which my honourable friend has just mentioned, test is being made available throughout England. This will identify about 90% of carriers and is the gold standard for this purpose. Using Public Health's regional laboratory standard operating procedure, the results of this GBS test are about 85% predictive of carriage status for up to 5 weeks. It should be used wherever there is an indication to identify GBS carriage. These sensitive tests have not been previously widely available at the request of health professionals and pregnant women within the NHS. There are some key questions I would like to ask the Minister to address. Will the Minister please use this debate as an opportunity to make a statement welcoming the gold standard enriched culture medium test for group B strep carriage, which is being made available from January 2014, which can be used if there is an indication to assess carrier state. From this point on, how does the Minister plan to reduce the incidence of GBS infection in newborn babies when the current risk-based strategy, introduced in 2003, has been shown to be not to be effective? Do we target rate for GBS infection in newborn babies? Do we have a target? I've always been somebody who's actually derided targets, but it seems to me in this case that maybe setting a target for the reduction of GBS infections may be a way to look at and to introduce a routine testing. Will the Minister confirm that the audit of practice suggested by the UK National Screening Committee to establish how well the new guidance is being implemented at a national level will study the actual practice in maternity units, will study the actual practice taking place in maternity units, rather than simply being an audit of policies without any check as to whether they are being applied in practice, because we actually do know these policies are not being put into place in practice in maternity units? What is the timescale for the feedback and advice to trust about how they can further improve their adherence to the RCOG and NICE guidelines on the prevention of neonatal GBS disease. What provision is being made for telling pregnant women about the risk of GBS infection in their babies? What provision is being made to educate relevant health professionals about the prevention of Group B Strep in newborn babies and forthcoming availability of the gold standard ECM test? Do midwives and do practitioners in maternity units even know that this gold standard test is being introduced in 2014? UK guidelines recommend that when GBS carriage is found by chance during a pregnancy, it should trigger the offer of antibiotic prophylaxis in labour. Why should women with unknown GBS carriage status be denied the opportunity to find out if their baby is at risk? I would like to pay tribute to the tireless work of Group B Strep Support, the charity and campaign group that has been working to raise awareness of this issue and reduce the death toll. And I also have a constituent who has sadly lost a baby to Group B Strep. The group has been a great help to me in preparing for this debate following a meeting with my constituent. 10 years ago, the Right Honourable Member for Witney, now Prime Minister, said here in this place in an adjournment debate, Group B Strep Support's aim, which I support, is for the routine test to be offered to all pregnant women with those who are found to have GBS at the 35 to 37 week stage, being automatically offered intravenous antibiotics. He actually said to the Minister opposite him, I hope the Minister will show great urgency over this issue. The Prime Minister, the Honourable Member for Witney, wanted to introduce and spoke for the introduction of routine testing. I echo his sentiments exactly.
Yeah.
Minister.
Thank you, Madam Deputy Speaker, and I'd like to congratulate my honourable friend, the member for the Bedfordshire, on securing this debate and raising what is a very important issue. The death of any baby is devastating for parents and their families, and it's important we do all we can to minimise the risks of such deaths. A very strong case has been presented today by my honourable friend. However, I'm sure the House will agree that, as I shall set out later, it is equally important we are guided in our decisions by professional evidence-based advice to ensure that any action that we take does not lead to potentially greater adverse outcomes or unintended consequences. A little bit of background, Madam Deputy Speaker, about Group B Strep and Group B Strep infection. Group B Streptococcus is one of many bacteria that can present in the human body. It is estimated that about 1 pregnant woman in 5 in the UK carries Group B Strep, and around the time of labour and birth, many babies come into contact with Group B Strep and are colonised by the bacteria. Most are unaffected, but a small number can become infected. If a baby develops Group B Strep infection less than 7 days after birth, it is known as early onset Group B Strep infection. Most babies who become infected develop symptoms within 12 hours of birth, and it's estimated that about 1 in 2,000 babies born in the UK develops early onset Group B Strep infection, and that's around 404 babies a year, and these are points that my honourable friend made earlier. Most babies who become infected can be treated successfully and will make a full recovery. However, even with the best medical care, 1 in 10 babies diagnosed with early onset Group B Strep infection will unfortunately die, and the infection can cause life-threatening complications such as septicemia, pneumonia and meningitis. Another 1 in 5 babies who survive the infection will be affected permanently. An early onset Group B Strep infection can cause problems such as cerebral palsy, deafness, blindness and serious learning difficulties. Rarely, Group B Strep can cause infection in the mother, for example an infection in the womb or the urinary tract, or more seriously an infection that spreads through the blood, causing symptoms to develop throughout the whole body. But it's also worth reflecting, Madam Deputy Speaker, at this point, how the UK compares internationally on rates of global Group B Strep infection. The reported rate per 1,000 births is 0.38 in the UK. In the USA, where there is testing, is 0.41. In Spain is 0.39. In France is 0.75. In Portugal 0.44. And in Norway 0.46. So even by comparison of other countries where there is routine Group B Strep screening at 35 to 37 weeks, the UK has relatively low levels of Group B Strep infection. I will give way in just one moment. My friend will allow me to make a little bit of progress. Because I think it's worth setting out for the record, Madam Speaker, some of the general improvements that are being made in maternity care that are helping to reduce Group B Strep infection and improve the quality of care that are available for women. And women, we all agree, should receive high quality and safe maternity services that deliver the best outcome for them and their baby. Maternity services feature prominently in the key objectives set out in the first mandate between the government and NHS England, and as set out in the mandate, we want all women to have a named midwife who will be responsible for ensuring she has personalised one-to-one care. And to help deliver this, there has been significant investment in the maternity workforce, and since May 2010, the number of full-time equivalent midwives has increased by 6.5%, that's about just under 1,500, and in addition, there are currently in excess of 5,000 midwifery students in training. So there is considerable investment going into maternity to make sure there is much more personalised care, which will lead to much safer care for women and their babies. And I will, of course, give way briefly.
I thank him for generously giving way. But would he not agree that in the countries where, if we were routine testing, we know that the risk-based strategy isn't working effectively for the reasons that I highlighted, that in countries where they do test, there is actually a far greater chance. We don't know what the numbers would be. The comparisons that you mentioned with the US and France and other countries, we don't know what their figures would be if they were using our assessment, if they were using the risk assessment that we use. The fact is they are routinely testing, and would he not agree that if we were routine testing, only then could we actually do a like-by-like comparison with other countries? And could he also, I really hope he's going to say in his response to this debate, could he actually say the specific reason why in the UK, in a sophisticated country with sophisticated maternity services, we are not routinely testing?
I'm going to come to these points a little bit later on in what I have to say, but I think just to hopefully reassure the honourable, my honourable friend, the fact of the matter is that when you're doing a test at 35 to 37 weeks, and the majority of babies that go on to die from Group B Strep have been born prematurely, a test at 35 to 37 weeks wouldn't have benefited those babies. So those babies would tragically have died in any case. So the test, as a test, to actually prevent those babies from dying, wouldn't have been an effective test or an effective screening test. And I'm going to say a little bit more about this later on, if my honourable friend will allow me to make a little bit of progress. But the first challenge for all of us, and I think paying tribute to my honourable friend for raising this debate today, is raising general awareness of Group B Strep, which is something that is very important amongst the healthcare workforce and amongst women more generally. And the Department of Health is working together with the National Health Service, the Royal College of Obstetricians and Gynaecologists, and the Royal College of Midwives, and the National Institute for Health Research and Health Technology Assessment, and the pharmaceutical industry to raise awareness of Group B Strep and reduce the impact of the terrible infection. The Royal College of Obstetricians and Gynaecologists has produced an information leaflet for women who are expecting a baby or planning to become pregnant, and this sets out information about Group B Strep infection in babies in the first week after birth and the current UK recommendations for preventing Group B Strep in newborn babies. In addition, information is also available on the NHS Choices website. But as all honourable members and honourable friends in debate today will agree, the focus is that we've got to prevent early onset Group B Strep infection from occurring as much as we can in the first place. And the Royal College of Obstetricians and Gynaecologists published updated guidelines on prevention of early onset Group B Strep infection in neonates in July 2012, which takes into account the latest evidence. It is important that services undertake local clinical audits to ensure the effective use of intrapartum antibiotic prophylaxis as recommended by the guidance. And following the publication of this revised guidance, the UK National Screening Committee suggested a formal audit of practice to establish how well the new guidance is being implemented at a national level. The Royal College of Obstetricians and Gynaecologists, in partnership with the London School of Hygiene and Tropical Medicine, have now appointed a clinical research fellow to carry out a one-year audit across the United Kingdom, which will undertake a review to see how units have revised and updated their local protocols since 2006, to use well-designed case studies to gather specific information about maternity unit policies by asking clinicians whether they would screen for Group B Strep and or other intrapartum antibiotic prophylaxis in the circumstances described, and also to assess the extent to which current maternity information systems are able to provide data on whether a woman has had an antenatal culture for Group B Strep, whether women were given intrapartum antibiotics, and if so, the antibiotics prescribed, the dose and duration, and whether the women had particular risk factors such as intrapartum fever. The audit aims to provide feedback and advice to all participating trusts about how they can further improve their adherence to the Royal College of Obstetricians guidelines on the prevention of neonatal Group B Strep disease. Clinical audit is a tool that is incredibly valuable in improving the quality of patient care. It's something that trusts do very often on an ad hoc basis. So the fact that we now have a national audit focus for Group B Strep disease, I'm sure, will help to standardise practice across all maternity settings and improve the quality of care that is available, so that we can look at which women are more vulnerable and more susceptible to developing Group B Strep, and therefore reduce infection rates. And of course, I'll give way.
I'd like my friend to give me a go. That's encouraging news. But again, the focus is on women who are at risk of Group B Strep. What I'm trying to advocate and push for is the fact that regardless of that all women, we don't know always which women are at risk, and in fact all women should be tested for Group B Strep. Every pregnant woman I meet now, I recommend buys a kit for testing Group B Strep. And whereas it's very encouraging and it's very positive moves forward that the Minister is indicating, however, it is still focusing on the at-risk women, which is what the risk strategy does now. We need to move from that. We need to move away from just the at-risk women. We need to move from 35 to 37 weeks. We need to move forward to full term and to all women and routine testing for Group B Strep.
Well, I'm hopeful that the audit that the Royal College of Obstetricians and Gynaecologists has put forward at a national level, which was something that I discussed with the Group B Strep group and the Chief Medical Officer at a meeting we held around this time last year to progress this work at greater pace, will put us into a better position to understand in particular which women are at high risk, whether units are picking up on those, birthing units are picking up on those women in a timely manner, and how we can improve the situation at a local level throughout the country, because in the past there has been quite a lot of variation in practice, broadly based on the Royal College of Obstetricians and Gynaecologists guidelines, but it's important that we do, and we know the devastating effects of this illness, put together a comprehensive audit tool that actually gathers data together properly to national level so that we can actually spread good practice and good guidance throughout. And I will come on hopefully to, if my honourable friend will be patient, to actually addressing some of the broader issues about screening a little bit later on.
Was it Minister very briefly?
Of course I'll give way.
Yeah, I'm very grateful to him. Earlier on in his remarks, he said that some countries which screen have higher rates of Group B Strep than we do in this country. Does he have any data, and would he perhaps write to my honourable friend and myself just to show what the progression has been since testing was brought in those countries? Because I think my honourable friend said in relation to Spain that it was falling. So it would just be interested to see how it's moving following the introduction of widespread testing.
And I'd certainly be delighted to do so. Of course, it is important, of course, to put alongside any research that's done. There's always confounding factors in that research. So, for example, there is some evidence that with Group B Strep disease that there are, amongst different population groups, there are different rates of carriage amongst different populations, and indeed the treatment of Group B Strep in different countries in terms of the clinical treatment in hospital, that's separate to the screening process, is of course variable. So we have to set that data alongside other practices which take place at a local level to interpret it in the right way. But I'm delighted to write out more broadly and to give that general information to my honourable friends and any other honourable members who would be interested. But coming now on to the issue of routine screening for Group B Strep, the UK National Screening Committee advises ministers and the National Health Service in all 4 countries about all aspects of screening policy and supports implementation. At its meeting on the 13th of November 2012, the UK National Screening Committee recommended that antenatal screening for Group B Strep carriage at 35 to 37 weeks should not be offered, as my honourable friend raised, and this is the reason for the debate. And the reasons that were given were that currently available screening tests cannot distinguish between women whose babies would be affected and those that would not. As a result, about 140,000 low-risk pregnant women would be offered antibiotics in labour following a positive screening test result. The overwhelming majority of these women would have a healthy baby without screening and treatment. In other words, a woman who screens positive for group B strep at one point in pregnancy may not necessarily be carrying the group B strep at the time of delivery, and therefore there'll be 140,000 women potentially on a current on an annual basis who would be given antibiotics who wouldn't actually have needed them in labour. There are also concerns, quite understandably, on the back of that evidence about resistance to some antibiotics used to prevent early onset group B strep, the long-term effects on the newborn and the potential for anaphylactic reactions in labour. Many of us will recall the Chief Medical Officer's report, the CMO for England's report, and she's particularly concerned about the risks posed by antibiotic resistance due to overuse. And using on that sort of size of population, there is of course a risk about antibiotic resistance developing, which would potentially have adverse consequences. And of course I'll give way.
I'm just interested in the comments that he's just made, because as I mentioned in the speech, it's penicillin, it's a narrow spectrum antibiotic. It's what a GP, and I know the minister's background, would give somebody for a throat infection. It's a widely, commonly used antibiotic. So does the minister not think that that particular point, the over-concern, is kind of over-egging the pudding slightly?
Well, what we do know is, and the Chief Medical Officer made this point very graphically in her report, I believe, that was published earlier this year, that overuse of antibiotics amongst people who don't necessarily need the antibiotics can lead to resistance developing in bacteria. And we know from the hospital superbug MRSA, there's VRSA, there are many other resistant strains of bacteria that are developing. So part of the challenge is to see responsible prescribing more broadly in the NHS to make sure that antibiotics are being targeted on those people who actually they will directly benefit from. And if it would mean that screening would lead to a high number, many tens of thousands of women being given antibiotics inappropriately for when they came to deliver their baby because they weren't at that point carrying group B strep, then I think the Chief Medical Officer's concern would be about similar resistance developing in this bacteria. And we already know the devastating consequences that occur from group B strep infection. And if we saw various resistant strains developing, that could potentially be a very unintended consequence which none of us would want to see, and something we need to be very mindful of. And I believe that's something the National Screening Committee were very mindful of in making their recommendations. The majority of babies, as I alluded to earlier, who die from early onset group B strep are premature and are sadly born too early to be helped by screening at 35 to 37 weeks. And 2001 data shows that in that year there were 39 deaths due to group B strep, but 24 occurred prematurely, and that's before the 35th week of pregnancy for these purposes, when screening would have been carried out, and so wouldn't have been those deaths would not have been potentially preventable through a screening programme. And it has been estimated that up to 49,000 women carrying group B strep at 35 to 37 weeks of pregnancy may longer be carriers, as we've just discussed, and would then be receiving treatment during labour. And studies of the test suggest that between 13 and 40% of screen-positive women will no longer be carriers at delivery. And there's also a potentially detrimental impact on maternity services of increasing the medicalisation of labour and with the increase in hospital births that we know we're seeing, the increases in the birth rate. We know that once we begin to have one intervention in labour, it potentially can lead to other interventions and a higher rate of caesarean section when perhaps that wasn't necessary in the first place. I'm not saying that's always going to be the case with group B strep infection, absolutely not, and far from it, but we know that when a woman enters a medicalised pathway on a maternity unit, that often leads to interventions that perhaps were unnecessary and can be quite distressing during labour, particularly if, as I said, many of those women who would be potentially put on prophylaxis would no longer be carriers of group B strep. So the advice from UK National Screening Committee is consistent with that of the Royal College of Obstetricians and Gynaecologists and the National Institute for Health and Care Excellence, NICE, I believe we've talked through a number of the issues about why that recommendation has been made. But I think it's also important in this debate, Madam Deputy Speaker, in the brief time that's left available to me, is to talk a little bit about some of the research that's going on. And it's estimated that a vaccine for Group B Strep is approximately 5 years away from development. And the first stage trials have now been undertaken, and wider population-based studies for safety and efficacy are in place in high prevalence areas such as South Africa. So a vaccine, I'm sure we'd all agree, would undoubtedly be able to undoubtedly be a very effective solution for Group B Strep, and I certainly will be doing all I can to push and nudge to make sure that vaccine is brought forward, not in a safe and appropriate manner, but in as timely as a manner as is possible.
Is the Minister then informing us that that vaccine would be widely available? And can I just ask him once more, and given everything that he said today, and I'm incredibly grateful, why does he think that countries like Spain and the United States of America and other countries have introduced routine testing when we are still seeming to be opposed to it?
I think, as I mean, it's difficult to look sometimes at how in various parts of and various regions of the States or Spain there are sometimes, I believe, variations in practice, clinical practice and the care of women during maternity services different to the ones we would have in this country. I think it's because we have in place very robust guidelines for trying to identify at-risk women while we're trying to tighten up on those through audit, while we have low rates. I'm not sure whether the same can always be said elsewhere in the world, and that is why they may have wanted to introduce a more crude tool through a screening test to help them potentially reduce their rates. As I've said, I will look into this matter and write to on my honourable friends to better inform them. But it is about research, it's about clinical audit as outlined earlier, making sure we have a proper national audit programme to carry out and develop better practice and good practice guidelines for Group B Strep. It's also about all of it, I believe, looking towards a vaccine as hopefully a long-term answer, not just in the UK, but throughout the world in dealing with this devastating disease. And it's also about making sure how we prioritise other research studies. At the moment, there's a study being carried out by the Maternal Health and Care Policy Research Unit, which is looking at women with Group B Strep sepsis, which will help us understand the physical impact that Group B Strep has on women's health, and also a second study providing information at a national level on the numbers of women and babies affected by anaphylaxis due to the antibiotic use in labour for Group B Strep or Group B Strep or presumed Group B Strep. And as I mentioned earlier, one of the concerns about a blanket prophylaxis would be the potential anaphylactic reaction that we know can occur when someone is allergic to penicillin or to other antibiotics for the woman. So I'd like to thank once again my honourable friend, the member for Mid Bedfordshire, for raising this very important issue. I hope that I've been able to clarify some of the reasoning set out behind the National Screening Committee's decisions, and I will of course be writing and further engaging with her and other honourable members to reassure them further that the government is taking this issue very seriously, and together I know we will get into a better place so that less families are affected by this very tragic illness. Thank you, Madam Deputy Speaker.
The question is that this House do now adjourn. As men of that opinion say aye. Aye. Of the contrary, no. The ayes have it. The ayes have it. Order, order.